Today, UPA wanted to take a moment to go over some information that we've compiled together covering telemedicine during the Waiver 1135 period, hoping that we can help streamline and consolidate the abundance of information that we're all being inundated with from the different payers and coding societies and things of that nature. So UPA will continue to collaborate and consolidate that information. We are putting everything that we are finding as far as source documents on our website. You can find that at upasolutions.com. The information we're going to cover today are some new documents that will be published out there along with this recording. It's intended to be a quick go-to meeting so that you can get it quickly, get on and off. Today with me in attendance, we also have Jennifer Bright, our coding manager here at University Physicians Association, as well as Jill Frazier, who's been kind enough to collaborate with us from the UHN and helping us, making sure for documentation questions like that, we get all that covered. So today you'll hear the three of us collaborate and go over the information that we have. First of all, if you've not been on the UPA website, that's where I'm at now. You're going to come down here. You can click on this information. It is going to launch the screen where we are keeping all of the information that we are making available to you, as well as the additional documents we're going to cover today. If you come down, anything new will be here, and then all source documents can then be expanded by going under any of these subtitles for past information. So we're going to start off and cover, for one, you've seen on that screen a grid, and we are going to go over that, making sure that you can kind of know where to find the information that we have available. Today, we've taken the common things that we've seen from the payers and Medicare that they're going to be covering through this period. We've put it on one sheet. We've put a lot of information as possible that will fit on the one-page screen here so that you can have it available on a one-page document. We're going to get straight into that and cover telemedicine. What is telemedicine? Telemedicine are visits that require interactive audio and video communication that permits real-time communication between you and the patient. So right now during the waiver, you're seeing Medicare lighten the restrictions on what is acceptable as far as the equipment and method that you're using for that. UpDocs, though, is a really good, secure method. Some of you may be using it, but Skype and FaceTime during this period are also acceptable forms of communication for you to use for true telemedicine. So that means for you and the patient, you can contact each other via FaceTime to where you can actually audio and visibly see the patient and do a visit, just the same as you would be in your office. One of the main questions we've been getting is, what is required and how do I do this? Medicare has set up the established patient visits as well as new patient visits, which are just two that we're pointing out here, as acceptable means of services that can be billed through telemedicine. But what that also means is there's no limitations, or they've not lightened the requirements as far as what you have to meet in order to bill those. So you still have to meet the same level of service that has always been required to bill these, whether or not you're truly face-to-face or contacting the patient through FaceTime. So for documentation requirements, it's going to be the same as if they were there with you face-to-face in the office. You'll need to document that the visit has been provided through telehealth so that any auditor or anyone looking at your records will know how that visit was initiated. The location of the provider and the patient. So you also want to capture those in your documentation, as well as any other persons who was attending the visit as well. If you've done 50% or more of your visit has been counseling, make sure that you capture your time. And really, being that it's a time-based service, it probably wouldn't be a bad thing if you just want to capture your time in general, even if it's not spent the majority counseling. I think that would just be beneficial. I think we all feel. Jennifer?
Great documentation.
Jill, do you want to add anything here along with that as far as the documentation requirements?
Yeah, just to kind of reiterate what you said, with telemedicine, you need to make sure that you have the same level of documentation as if that patient was right there in front of you in a face-to-face visit. All diagnoses should be supported with MEET in your note. That means monitor, evaluate, assess, or treat. And even though, you know, this is virtual, you still need to make sure that you are reporting your patient's chronic conditions or your HCCs. So even though perhaps you're seeing this patient just for an acute visit, you should still go ahead and report those chronic conditions that they have at that time that affect your medical decision making. Are any of their symptoms related to a chronic condition, or is that chronic condition stable? What kind of medications are they on that could affect your treatment? All of those things should still be captured, even though this is through telemedicine.
Okay, very good. So for that, we've tried to put together this table as a reminder. We've done established and new patient visits there. Keep in mind that for an established visit, you only have to meet 2 of the 3 components between a history, physical exam, or decision-making. So what that means is the highest level of the 2 will be the level in which you can bill. So if you've done an expanded problem-focused history, you've only done a minimal physical exam of 1 component, and you've got a decision-making of low, then you would bill a 99213 because the 2 of the 3 have to meet in order for you to bill that level of service. One of the main reasons we've put this here too is because a common question we've been getting via telemedicine is, how do I do the physical exam? Like, how do I capture that? How do I document that? So we put this in here, and the numbers here are representing the systems or organs that you're covering during your physical exam and how many you have to cover to qualify for a level of visit. So if it's 2 to 7 for a 99213, then really as long as you're capturing 2 body systems, and just a few examples that we've went through, some things that we feel could be covered via telemedicine is like general appearance, things like no acute distress, chest, you know, is the patient normal breathing, neuro, clear speech, skin, no lesions or rashes. So that gives you an idea. Psych, normal judgment and insight, normal mood, and those are some ideas of things that as you start to go through, based upon your specialty, that you could kind of capture, and making sure that you're getting those physical exam components documented and in your record, even though you're being via telemedicine. You know, if they've got a wound or things like that and they're showing you those things, those are some things that you can still assess via visual, audio. For new patients, then it's 3 of 3. So it is harder on the new patient visits. And as you can tell, then the physical exam components does play a big part because you have to meet all 3 levels. So even though you may have a detailed history and a low decision making, if you've only captured 1 component on the physical exam, you're going to then have to bill a 99201, even though your history and decision making was much higher. So you want to kind of make sure on those physical exams you are kind of going through and capturing the things you can, because there are still plenty of things you can capture via telemedicine, which is why Medicare is making these codes available through telemedicine, because you can still do quite a bit.
And these are based on 1995 guidelines. So if you are using 1997 guidelines, the components for physical exam, history, and medical decision-making do slightly vary, so you want to use your reference material appropriately if you're using 97 guidelines. These are based off of 95.
Okay. And again, these are just the 2 services. If you want to get a full list of codes that CMS has approved, we will have that is on the UPA Solutions website, and you can go out to the Medicare MedLearn, and they do publish a full list of codes that can be done. The next one we want to cover is telephone visits. So these are time-based codes that you can use to report non-face-to-face services. Now, an important thing here on telephone visits is these are for established patients only. And it has to be done by a qualified physician or healthcare professional who is and can bill evaluation and management services. So it can't be just that your nurse or your LPN had a phone call with the patient. It actually has to be a phone call with the physician, nurse practitioner, PA, one of those professionals who are enrolled and can bill for evaluation and management services. But if you're doing that, one of the big things too on these codes is making sure that you're not just having a conversation with the patient that they just had a visit 2 days ago, they went home and they called back because they had a question about the prescription or the treatment plan that was just discussed. So a big thing here is that it can't be for anything relating to an E&M service that they just had within the last 7 days. However, if you do have a patient that was you just seen in the office, but they went home and now they've got a new issue. Let's say they've all of a sudden got rectal bleeding and they need to call back in, and that issue was not there when they had their visit. That is a new problem. It will qualify. Now, if you tell that patient you need to see them, that the condition does warrant a true face-to-face service, and you bring them in within 24 hours, then no, you cannot bill for it because you're going to be getting reimbursed for that when you bring them in within the 24 hours for your visit. But if it's something that you can take care of and you can give the patient some advice, direction, a treatment plan just over the phone, then yes, that is a billable service as long as it's not related to a service that has been done within the past 7 days or going to create a visit within the next 24 hours. So on these, you are still going to document your assessment, your plan, the time, because again, these are time-based codes, so make sure you document your time and any persons in attendance with the phone call. Jennifer, Jill, anything to add on those?
No, I think that covers the basics.
Yes, I think
the one
that's
thing
good.
that you'll notice that we put here is this G2012, which you're going to say, well, wait, that's a virtual check-in code. Why do you have it under telephone visits? It's because Medicare does not cover the 99441 through 99443 for a phone visit. Medicare wants you to bill this virtual code, the G2012, which a phone is included in that. We're going to repeat the G2012 again when we come down to virtual check-ins. But we wanted you to be able to have that there, that's Medicare. It's a 5 to 10 minute telephone call. And that way, if you are doing a Medicare patient, you would know that you would need to use the G code, not the 9944 series. A question that we've had is, because that G2012 is only for 5 to 10 minutes, what if I had a 25-minute phone call with a patient? Do I bill that times 3? Medicare has what we would call a MUE of 1 with the G2012, meaning they're only going to pay for 1 unit. If you feel that you need to bill and it's one of those where I'm going to fight for that, if you want Medicare to pay for more than 1 unit, we would have to then appeal that and send in medical documentation asking them to consider that for reimbursement of additional units. On that, you would just need to work with us. If UPA is your revenue cycle management billing office, then communicate that to your contact here that you feel strongly that needs to be reimbursed, that you spend a lot of time with the patient and your documentation clearly shows why and supports. And then we'll work with you on doing appeals if we need to get that paid at additional units. But right now, no off the cuff. At first claims processing, Medicare is going to only pay 1 unit of the G2012. Virtual check-ins, these again are established for brief communications initiated again with an established patient. The same thing exists here with it being unrelated to a condition that was treated within 7 days and not going to lead to a visit within the next 24 hours. So we just covered the G2012. Know, though, that it can be more than just a phone call for that code. It can be an audio visual, it can be a text message, an email, or a portal. So these really kind of were intended by Medicare to capture a brief 5 to 10 minute communication via any of those modalities that you may have. The difference between that and the G2010 is that it is for pre-recorded. So let's say the patient pre-records a video and submits that to you, and you then, after the fact, look at that and then contact the patient back as you have time. So that's going to be the difference between the G2012 and the G2010 is the fact that the 10 is a pre-recorded. And if you notice, there's no time established to that code.
Also note that for documentation purposes on both of those virtual check-in codes, that verbal consent must be obtained to treat that patient and be documented.
Okay. And those two, I think if you don't have those, we feel that when you start that visit, you need to make sure that you get that patient's verbal consent and documented in the chart that the patient gave it. So it may not, because this has happened so fast, we've not had a chance to educate our population, our Medicare population, that these are covered services. So for that reason, you may not have that documented in your record, but know that you can capture it before you start the visit via virtual check-in. The next one is for those that actually have some functionality more with their EHRs through a patient portal. So you could actually have some chatting interactions going back and forth through your portal. And Medicare does have these unique codes for online e-visits. Again, it's for established patients. This one is in the fact that it can be captured over a period of 7 days. So it's a little bit different that it may be conversation that takes place little by little, and you accumulate your time over a period of 7 days. It doesn't mean it has to go 7 days. If you know that you've been talking to this patient on and off all day in little increments, but you've come to a solution and you're kind of done and you want to go ahead and submit your billing, you can. But if you end up communicating with that patient over a period of 7 days, then your time would be aggregated together and you would build a level of service that would correspond to the time spent. They have two different codes set for this. So for most of those who are physicians, again, established providers who can bill for their services, physicians, midwives, MPs, CRNAs, are registered dietitians of those nature, you're going to use the 99421 through 423 series. And again, you're going to see your time there broken down. If you are more of a PT or an occupational therapist, then you have your own set of codes and they're G codes. So we have those there too. And again, you would just use those versus the 994 series. Again, you would need to document your assessment, your plan, the time, and the person in attendance. So you can see for a lot of those, the documentation requirements are kind of consistent once you get to some of those more telephone and virtual and online codes of what you need to capture in your record. So those are what we're finding out as the most common traffic codes being used right now in telemedicine. As we come on down, you're going to notice we have place of service there, O2. O2 is the place of service for true telemedicine. So on those, you're going to use, which are these codes up here where you're doing actual FaceTime or Skype. We know for sure the place of service is O2. We are going to give the disclaimer that CMS has not been very clear because the virtual codes and the e-visit codes are different. They fall outside of a different category than telemedicine, even though it seems the same. Medicare has not been very clear in what the place of service is. Right now, a lot of us in the community are waiting for CMS to address that question specifically. Right now, we're going to say use O2 because we feel like under this waiver, most payers have adapted their system. Us being your revenue cycle management on the back end, we will watch for those. We'll watch for denials. If it needs to be different, we'll communicate that to you. We'll work with you getting your claims corrected and back out the door as quick as possible should Medicare or a payer want something different. And again, we do know that we have a few payers that can be different, and we will cover that when we get to the payer grid and what they cover. The modifiers as well, there's several modifiers. It doesn't mean you apply all of these, no. We've tried to kind of list for you what payers wanting what. Medicare really does not use the modifier to identify telemedicine except for when it's the stroke cases for inpatient, and that is the GO. So G0. So if you are doing a stroke case, then that would be the only time Medicare would need a modifier. The other payers have been a little bit different. Cigna continues to be a little bit different for us. They're wanting a GQ, which if you read the description of that, it really does not make much sense to us. However, their current guidance does lead us to use GQ if it is non-related to COVID-19. If it is a positive COVID-19 case, then you're going to use your CR. And then United Healthcare is listed optional between a GT and a 95. Now, what I am going to kind of tell you, some of you on your systems and your software setup, in order to get things to work and to translate correctly, we have sometimes had to use a modifier. You may see a GT always there. It doesn't mean that that's going to necessarily go out on your claim, but it could mean based upon your software configurations, we need a way to identify that it's telemedicine, not just a regular E&M visit in the office face-to-face. So don't be confused and maybe ask questions if you see that in your EHR or you see it in your coding. It could be there just for system configuration. This tool is going to be published out on the upasolutions.com website for you to print and to use and to go over with your providers and helping them understand mainly what codes to use and the documentation requirements, because we're hoping that will be helpful. It's got really the bulk of information you need all on a one-page item. So flipping over, the other document we want to make sure that is on our website that we want to make sure that you can see. Hold on one second. Let me switch gears here and get it brought up. Is the payer grid, which is here. Just keep in mind, too, this payer grid, you can click here to view a PDF and print out a nice, bigger version. If you click on it, it is going to launch this way for you so that you can see it nice and big and print it off. This one, we're keeping up with what payer pays and is covering each item. This information has been changing really daily. Hoping we're getting to a place where it's going to slow down, that payers have had time to catch up with their logic and get their systems configured and ready. But know to check this frequently because we could make changes to the document at any given point in time. Across the top, we've got the type of services, and then down below, we've got the payers and what services they're allowing coverage for. So you can come down, find your payer, and then things that are unique like Cigna. We've got documented over here which modifier for what reason, Medicare. We've added TriWest, which was a new one we just got information on last week. So hopefully this grid will help give you some guidance too on who's covering what, the time frames. Keep in mind, like for Cigna, we're having to use place of service 11. So that is going to be something you would need to work with your billing office. Us here at UPA, we know that. We'll be working that for you on the back end, getting that for you so you don't have to worry about that. But this is the other two main documents we want you to use. If you have additional questions, be sure and reach out to us. A couple things we did want to cover. A question we had was on well visits. So we wanted to address that question. For routine preventative care, let's say it that way, we have found that for those visits, it does require a comprehensive exam. And for that reason, we do feel it's going to be very difficult for you to do that via telemedicine because it's going to be hard to give the patient that full exam that they need. So we're not certain right now that it could change. I think, Jill, you've had some conversations back and forth with Humana. But I think for right now, we're saying we feel that could be a very difficult service to provide via telehealth. Mm-hmm. The other question.
Right now, Humana is saying that they're not sure even if annual wellness visits that don't require the comprehensive, physical exam component, they're not even sure if those are going to be approved either.
Okay.
But we'll of course keep everyone updated as soon as we hear something.
And do you guys want to cover, you and Jennifer, past visits? Because I know that was another question we had.
Yeah. Humana has also said from their end that as of right now, PAFs will not be covered.
Yes. And for Blue Cross Blue Shield plans, they are currently only covering telemedicine via office visits and as well as phone calls. So the patient assessment forms at this point we are assuming will not be covered via telemedicine unless new directive is provided, and we'll update you at that point if we do receive that information from the payer.
Okay. All right, and the other main thing is for those of you, if you find that your office wants to start doing telemedicine, keep in mind that you will need to do some system setup. If UPA is your billing service, then make sure you contact us so that we can help make sure that your service centers and things are set up to properly translate to bill the right place of service code of 02 when necessary. And that if we need to code, even if you're doing inpatient, because keep in mind there are some inpatient services that do qualify for telemedicine. If you need MedAptis or some of those applications configured or your favorites set up, or you have questions about inpatient, which we've not spent a lot of time on here, be sure and reach out to UPA so that we can help you. But even if we're not your billing service, you will need to make sure that you do some configurations to get the correct place of service going out on your claims. All right, we hope that you find this helpful. Just continue to watch our website for any updates, and if you have questions from anything we've covered today, you can reach out to us here at UPA. Thank you.